Welcome to our module. I'm Rania Said Mohammed, Demonstrator at Community Health Nursing Department, Faculty of Nursing, Mansoura University, and we will talk about how to appraising intervention studies. Upon completion of this module, you will be able to apply validity criteria to intervention articles, interpret relative risk, absolute risk reduction, and number needed to treatment. Finally, apply the result to your patient. After we have searched about evidence, we need to decide if both valid and important before deciding if can we apply to individual patient. The order in which we consider validity and importance depend on individual preference. Now, we will recall our PICO. Patient or problem was adult obese woman with type 2 diabetes. Intervention was bariatric surgery. Comparison was standard care. And outcome was weight loss and control of diabetes mellitus. So, our PICO clinical question it was in patient with type 2 diabetes and obesity. Is bariatric surgery more effective than standard medical care therapy at increasing remission of diabetes mellitus? So, using skills for searching on and found RCTs to address your question. When we are reading any article, there are three overarching questions. They are the results of study valid? What are the results? Will the results help me in caring for my patient? In order to assess bias, we look at validity. The issue of validity speaks to the truthfulness of information. Validity criteria should be applied before analyzing study data. If the study is not valid, the data may not be useful. Different criteria for validity of article are used for different types of questions. Depending on validity and article, we can classify it to level of evidence and degree of recommendation. At first, we should determine hierarchy of evidence. When we evaluating evidence for effectiveness of an intervention, clinicians often found it helpful to use a system to determine the level of evidence and degree of recommendation for particular study, so that our intervention question we will use RCT type of study design. Now, let's read the article we found using our PubMed search about bariatric surgery versus intensive medical therapy in obese patients with diabetes. In addition to identifying the level of evidence hierarchy, you must also consider critically appraising of the study's overall quality and the study's internal and external validity, which internal validity that could potentially impact the outcomes of study, including interaction between patient assignment, competing intervention, history, maturation, and experimentation, and external validity refers to generalizability of studies result to actual clinical practice. Information about validity of the article is found in method section. Study practice such as randomization and baseline homogeneity, concealment, allocation to groups, blinding, intention to treat, and finally equivalent experience of group. The first question we need to ask is were patients randomized? Randomization should be theoretical ensure that each group of subjects is similar to baseline, so that no extraneous variable such as known and unknown prognostic factor compete with an intervention to explain observed outcome. Extraneous variables that could potentially affect the outcome in studies treatment effect include patient age, race, gender, symptom duration, and treatment expectation. The assignment of patient to either group, treatment or control must be done by random allocation, may be from coin toss and computer-generated randomization table like this. Read the following passage from article about randomization at method section. Where patient was randomized, According to this paper, randomization was be done. Concealment of allocation. Randomization sequence should be consulted from clinician and researcher of the study to further estimate selection bias. Concealment is part of enrollment process and ensures that a researcher can protect or change assignment of patient to a treatment group. If allocation is not consulted, it may be possible influence outcome by changing enrollment order or order of treatment. Concealed allocation can be done by using a remote call center for patient or using a weak envelope with a sign. Read this passage from the article and say that consult is occurred by computerized system for generating random number. Blinding. Blind means that people involved in the study don't know which treatment were given to which patients. Patients, researchers, data collectors, and others involved in the study shouldn't know which treatment is being administered. In pharmaceutical study, it's usually possible to blind all categories. This is usually not possible in the studies of physical intervention. So, it's difficult to blind patient to treatment such as surgical procedure. Blinding the doctor or researcher is needed to get out the results. Intention to treat. The study should begin and end with the same number of patients in each group. Patients' roles to the study must be accounted for the risk making. It's important for clinicians to know if the patient withdrew from the study due to full resolution of the symptoms, reasons unrelated to the study, or because persons experienced worsening in the status that was directly or potentially related to examination or treatment program provided by study protocol. Good studies will have better than 80% follow-up for either patients. When subjects are lost for follow-up, it may be still possible to include data from all subjects in final data set using by intention to treat approach, which has been used in a variety of recent published studies. Equivalent experience of groups. The treatment and control group should be similar for all prognostic characteristics except whether or not they receive the experimental treatment. A good way to verify the result is the randomization result is similar group to reference in baseline characteristic table. As you say, table 1, baseline characteristic of the patients for experimental and control group as age and so on. As you see, is done. If we decide that the study is valid and we can go to look at the result, we consider whether the study's results are clinically important. For example, did experimental group show significantly better outcome compared with control group? We also consider how much uncertainty there are about the results, as expressed in the form of p-values, confidence interval, and sensitivity analysis. When we review the results, we typically ask how large was the treatment effect and how precision was the treatment effect. We want to balance the size and precision of the treatment effect with consideration of clinical significance and statistical significance. Article may report the result in a variety of different ways. It's important for you to calculate treatment effect in terms of absolute risk or benefit and relative risk or benefit, number needed to treatment, and many articles may not report it. You should be calculated in a similar way. As you see in this passage from the article, it's report us about experimental event rate and control event rate, which experimental event rate is number of events divided by total number in experimental group. In this case, the result was 50 divided by 20 equal 75%, and for control event rate is number of events divided by total number of control group. The result is 2 divided by 20 equal 10%. This sample calculation allows you to evaluate the result of any article in some way. If necessary, the way of article words to present its result to you. as we talked before about experimental event rate and control event rate. So we can calculate relative risk and absolute benefit increase, which relative risk is the ratio of the risk in experimental group compared to risk in control group. The result is experimental event rate divided by control event rate, which equal 7.5. And for absolute benefit increase, it's different between rates of event in control group and experimental group that refer to good event as result of intervention. The result is experimental event rate minus control event rate, which equal 65%. After we have calculated absolute benefit increase, now we can calculate number needed to treat, which is number of patients need to treat to prevent one bad outcome or produce one bad outcome. In this case, the result is 1 divided by absolute benefit increase, which equal 2. And for confidence interval, which confidence interval 95% usually used to consider the study is low risk bias, include true treatment effect 95% of time. Clinical significance versus statistical significance. Clinical significance has little to do with statistic and it's a matter of judgment. Clinical significance often depends on the magnitude of the effect being studied and answer the question, is difference between groups large enough to be worth achieving? You remember that studies can be statistical significance, not yet clinical significance. Once we have determined the risk of bias and interpret the result, we can ask how we will help the result to patient care. So we ask it, can the result be applied to my patient care? Were all clinical importance outcome considered? Are the likely treatment benefit worth to potential harm and cost? And thanks a lot for you.